Good evening, everyone. I welcome you all to the May chapter 2025 Therapeutic Forum Sri Lanka College of Internal Medicine. This therapeutic forum was initiated in the view of upbringing the knowledge and practices of practicing clinicians throughout the country with regards to specialist knowledge. Without further ado, I would like to invite Dr. Krishant Jayasekara, President, Sri Lanka College of Internal Medicine, to address the gathering.
Thank you very much, Ranga. Warm welcome to the fourth Therapeutic Forum for year 2025. And this, as Ranga very clearly said, this was actually initiated a couple of years back to enhance the therapeutic knowledge on therapeutics that are actually confined, not only confined to the internal medicine, to other specialties as well. So we do have this has become very popular among many, you have many internists as well as trainees, and also we have invited the trainees from other specialties to join when there is a speaker from the other specialty. So there are a lot of other trainees and medical officers joining this very popular forum. So so we have actually fulfilled the objective of this forum over the years, and I'm actually proud that we have a excellent speaker today, Dr. Chinthaka Appuhamy. He's a consultant radiologist, senior lecturer attached to the Department of Surgery, University of California, and he would be taking us through the interventional radiology. We know interventional radiology has actually revolutionized over the last couple of years, mainly in the diagnostic, but now it's come into the therapeutics as well. And it's been very useful in most of the specialties, and it is coming to the internal medicine specialty as well. So without further ado, may I invite Ranga Gunasekara, the specialist in internal medicine, the moderator, to introduce the speaker and proceed with the webinar. Over to you, Ranga.
Ranga is muted.
Ranga muted.
Dr. Chinthaka Appuhamy, senior lecturer and a consultant radiologist attached to Colombo North Teaching Hospital, Ragama. He's MBBS, MD Radiology, FRCR UK, MEd Singapore, EBIR European Board of International Radiology, European Diploma of Radiology, and he has fellowship in Vascular Interventional Radiology, Tang Tok Seng Hospital, Singapore, fellowship in Neuroradiology, National Neuroscience Institute, Singapore, fellowship in General Radiology, Sir Gangaram Hospital, New Delhi, India, and he has authored several chapters in books related to radiology, protection devices in endovascular practice, Yearbook of Vascular and Endovascular Surgery in 2016, Neuroimaging in Geriatric Psychiatry, and Handbook of Interventional Radiology for Medical Undergraduates. May I cordially invite Dr. Chinthaka Appuhamy for this lecture. Thank you.
Thank you very much for the introduction, and it's a great honor and privilege to be here and present in front of such a large gathering. It's 144 and counting. Ranga, can I share my screen now?
Yes, Chinthaka, yes.
Yes.
Yeah. May I go to the presenter view?
Yeah.
Yeah, it's in
We can see you. We can see you.
Okay, right. Okay, so this is the topic we are going to discuss. And again, I'm really grateful to be here. And I will briefly discuss about the interventions we do and how it can apply to our day-to-day practice. So the intervention
Chinthaka,
radiology,
Chinthaka,
yeah,
can you go to the presenter view? I think it's on yeah. Do you want the presenter because we can see the other slide, next slide as well. So you
okay. Then I'll go to the normal
please,
thing.
yeah.
No,
Yeah,
yeah,
so
That's
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 fine.
better. That's
Yeah,
better.
that's fine.
that's
Yeah,
fine
yeah.
with me.
That's,
Right. Okay. Hope you can hear me well.
yeah, we can,
Yeah.
we can hear you.
Right. Okay. So the imaging modalities we use for interventions are starting from X-rays, fluoroscopy, ultrasound, CT, and sometimes MRI. So these things will be used to precisely target the therapy. So in interventional radiology, it is essential skills of an interventional radiologist are in diagnostic image interpretation and the manipulation of needles and the use of fine catheters and wires to navigate under imaging control. In current practice, IRs play an important role in patient management. So we can broadly divide these procedures into two entities like non-vascular interventions and vascular interventions comprising arterial, venous, and lymphatic. If I elaborate a bit more on non-vascular interventions, we try to do biopsies from difficult locations such as para-aortic, mesenteric, omental, vertebral, pelvic, and so on. And I'm going to show you some examples of these biopsies. This is one such example. Can you hear my cursor moving?
Yes, we can see you. Yes.
Right. Okay. So this is contrast enhanced axial CT abdomen showing abnormal soft tissue area in the root of the mesentery and just above the right ureter. So this is the psoas muscle, and it is not practical to come from the anterior aspect unless you go for laparoscopic assistance. So what the route we got here is the paravertebral approach through the psoas muscle into the lesion. So this is how we place the coaxial needle through the psoas muscle, and patient is in the prone position under local sedation. And with the help of the coaxial needle, through that we can safely put a 18 gauge co-biopsy needle, and we can take several samples for histology, culture ABST, and TB, and so on. With advanced ultrasound scanning, with high frequency, high resolution ultrasound scans, such as in this illustration, the omental thickening, or rather omental cake, can be seen like this. And the underlying bubble is here, and the star marked here is the thickened omentum. So omental biopsies can be carried out with real-time image guidance using high-resolution ultrasound scan. This is an example of a bone biopsy. Again, transpedicular approach. Patient is in the prone position under CT guidance. These are bone windows. And as you can see, we have gone through the pedicle into the destructed disc or the vertebral body. And through that, we can aspirate and take several samples for various investigations. These pelvic abscesses, deeply seated pelvic abscesses, are notorious at times because it's very difficult to reach. Posteriorly, you get thick muscle and the skeleton, and anteriorly, there are so many visceral organs. So in this patient, continuous fever following a surgery, and there was a small presacral abscess here with a gas locule, if you can see here. And patient is in the oblique position in the CT room, transgluteal approach over a wire. The needle is inserted through that. This is again the Seldinger technique, as you all know. Through the needle, put a wire, and over a wire, the tract is dilated, and a wide bore pictal catheter is placed. I will briefly discuss about tumor management now. So always the tumor management is going to be a multidisciplinary approach, which comprises physicians, surgeons, diagnostic and interventional radiologists, pathologists, very important, and clinical oncologists. When it comes to primary hepatocellular carcinoma management, we follow Barcelona Clinic Liver Cancer Staging Guidelines, also called BCLC guidelines. In these guidelines, if you come across this algorithm, the first line treatment options for early diagnosed HCCs or hepatomas are ablation, resection, and transplant. So all three options carry expected survival of more than 5 years. Untreated hepatomas, average lifespan is 13 months. So it's well above the normal sequelae of a normal hepatoma in a patient. So ablation is within one of the first line treatment options. Then comes TACE. For the intermediate category patients, when the patients are not suitable for the best three options, we carry out TACE, or we call it transarterial chemoembolization. And very selected population, radioembolization using Y90 is carried out when these patients are not suitable for above options. Now I'm going to talk about transarterial chemoembolization. It is widely used, like I said earlier, for the patients not eligible for resection, ablation, or transplant. The whole rationale behind TACE, or transarterial chemoembolization, is, as you all know, 80% of the blood supply to the liver comes from the portal vein. When it comes to hepatomas, the tumor gets exclusive blood supply from the hepatic artery. So if we can cannulate the feeders and directly inject the chemotherapeutic drugs and block the blood vessels of the tumor, we can safely spare the surrounding parenchyma while we completely knocking off the tumor. So that is the main principle here. So the approach is usually femoral into the aorta, then find out the celiac axis, going into the proper hepatic artery, do several selective angiograms, and find out the feeder or the multiple feeders supplying the tumor. Then we place our microcatheters in the feeders and give the chemo drugs. The usual drug is doxorubicin mixed with this lipiodol. This is the oil-based iodinated contrast medium specifically designed for this purpose. This is one such example of a right side large hepatoma. As you can see, the microcatheter is placed in the right hepatic artery, and this angiogram shows at least 4 feeders supplying this tumor, all coming from 2 from the segment 8 artery and 2 from segment 5 artery. So I'm sorry, that was the primary catheter, and through that primary catheter, another microcatheter is advanced into the feeder. So this is the segment 5, one of the feeders, and we inject the combination of drugs. So while injecting, you can see the accumulation of the drugs within the tumor, sparing the surrounding parenchyma. So there is no contaminating the surrounding parenchyma. So it is a super selective catheterization, super selective injection, and embolization. So once the embolization is done, the completion angiogram shows the complete knockoff of the feeding vessels. And if you take an X-ray, the lipidol cast with the drugs can be seen like this. When we do on-table cone beam CT, the current C-arms or fluoroscopies, they have the cone beam CTs. On table, we can do a CT and see. So this is one such example where good accumulation of the drug into this segment 6 large hepatoma. And this is rather diffuse hepatoma, almost involving most of the lobes of the right lobe of the liver, most of the segments of the right lobe of the liver, and again, satisfactory accumulation of the drug. Like I said, in current practice, the newer machines, we can do on-table CTs, and we can reconstruct the blood vessels with, I'm sorry. Can you see the full screen again? I got a call. Sorry.
Yeah, we can see you. Yes.
Right. Okay. Right. Switched off my phone. Right. So this is the last two image. The bottom line images shows vascular navigation techniques where the 3D reconstructions gives a proper visualization of feeding vessels. So this is the tumor, two feeders arising from this segmental artery. So these things are helpful for us to negotiate our catheters precisely into the feeding vessels. So in that patient, once the test was done, completion CT clearly shows dense accumulation of the drugs within the tumor without contaminating the rest of the liver. Right. Back to the algorithm of BCLC guidelines, there is a place for radioembolization. Like I said earlier, the technique is similar, but the mechanism is different. This time we use Y90, which is not available for this treatment at the moment in Sri Lanka. But in India, Chennai, Singapore, they all have this technique. And again, same technique, the catheters negotiate into the feeding vessels and Y90 is delivered. So it's kind of a internal brachytherapy mechanism. So once the isotope is accumulated within this tumor, the isotope cameras detect the dense accumulation like this. And this is one such example of a Sri Lankan patient. 6 months later, the segment 8 hepatoma is nicely necrosed. And even after 3 years, he was stable and there was no tumor recurrence after Y90 treatment, that is radioembolization. Now I'm going to discuss about tumor ablation, one of the best options for hepatomas after resection, transplant, and ablation. Like I said, more than 5 years survival, and this option is in par with resection and transplant. So the modalities we use for image-guided tumor ablation are radiofrequency. The earlier we started with radiofrequency, but now we mainly adapted into the microwave. Then at other centers, they have cryoablation, HIFU, laser ablations, and irreversible electroporation. So out of all the modalities, what we have here is RFA and microwave. Compared to radiofrequency, microwave is more powerful and it gives a uniform ablation. And it reduces the heat sink effect. And so overall, all in all, the outcome is more compared to RFA. So this is one such example. As you can see, it's a sterile technique under moderate sedation. That is the microwave antenna. And this is real-time ultrasound guidance. And we are trying to insert the microwave antenna like this into this segment 6 hepatoma. It's about 2 centimeters. As you can see, the tip of the antenna going to be placed at the distal margin of this tumor. Then the antenna is connected into a microwave generator and the heat is produced. We expect it to be up to 105 Celsius. And the target is to ablate the entire tumor and take another 1 centimeter of the normal parenchyma around the tumor. So we expect a complete destruction of the tumor in this patient. So like in liver, in selected patients, we do ablations for renal cell carcinomas and metastatic deposits of which are not operable, lung malignancies. Then osteoidosteomas in bones and thyroid. Currently, we do thyroid ablations for non-malignant nodules when the patient is not suitable for open surgeries or when the patient is requested for ablations. But in other centers, they do for micropapillary CA thyroid as well. So these are some of the examples. In this patient, RFA was done, and this is segment 8 hepatoma, nicely seen. That's how you diagnose a hepatoma is when in the arterial phase of the CT, it gives avid enhancement. So this is arterial phase and wash off in the portal venous phase. So hepatomas is a radiological diagnosis where you don't do biopsies. If the criteria is fulfilled radiologically, you safely conclude it as a hepatoma, especially in the background of cirrhosis. So this is one such example. This is the radiofrequency antenna is placed in the segment 8. And another patient, before the ablation, avid enhancement, like I said, hepatoma in background of cirrhosis, hypertrophic choroidal lobe and the left lobe, irregular outline. As you can see, all the features of cirrhosis is there. But there is no sites, there is no decompensation, no portal vein thrombosis. So this is a nice solitary hepatoma within the criteria for ablation. And this is following ablation. There is no residual nodular enhancement in the periphery. That means we have taken the entire lesion. Another example, segment 6, subcapsule locations. These subcapsule locations in the recent past, it was a relative contraindication, but with these advanced imaging techniques, we do ablations for almost all the hepatomas, irrespective of the location. The same patient, these are the follow-up images showing complete destruction of the tumor without tumor recurrence. Like I said just now, this is a post-ablation image which shows the ablation margin has gone up to the pericardium here under the diaphragm. So they are not contraindications anymore. Like in this patient, you see nearly 1 to 1.5 centimeter hepatoma right at the edge of the heart under the diaphragm. So if you can precisely place the needle, you can ablate them completely. But mind you, we need a good sedation for these patients, not to change their respiratory pattern, and continuous cardiac monitoring is essential just to make sure that patient is not developing any arrhythmias because of the generated heat near the heart. So the same patient, soon after the procedure, the CT reconstructed images shows the ablation margin has gone up to this level without damaging the heart. So that's about tumor or rather hepatoma management. I will now briefly discuss a few key points about TIPS. That's transjugular intrahepatic portosystemic shunt. You all know when it comes to fibrotic liver, there is developing portal hypertension. So then as a sequelae, there is a lot of portosystemic shunts like this towards the cardia, the spleen, and towards the superior rectal vessels. And at the same time, so the patient can develop massive bleeding. And at the same time, some patients present with refractory ascites. That is one of the main indications for these TIPS. So whole rationale about this TIPS procedure is we create an artificial tunnel across the liver, fibrotic liver, from the hepatic vein into the portal vein. Usually, the technique is to tunnel it from the right hepatic vein into the right portal vein like this. So, as the name implies, transjugular approach. So, the catheters we are going into the system through the jugular vein, then into the SVC to the intrahepatic IVC, and from the IVC, puncture is done under ultrasound and fluoroscopic guidance through the liver into the portal vein. So when we are in the portal vein, we put the wire and put catheters like this and balloon dilate this artificial track. Then the large guiding catheters is introduced from the hepatic venous side into the portal vein. So this is one such example. Once we put the guiding catheters and do a diagnostic run like this. As you can see, there are several portosystemic shunts going towards the stomach. So this is before the stent placement. So there are specially designed metal stents for TIPS procedure, such as this one. And this is after placement of the stent from the hepatic vein through the fibrotic liver into the portal vein. So this is a final angiogram, venogram. You can see the almost all the blood is shunting from the stent towards the heart, and there is great reduction of the portosystemic shunts that we can experience on table. Right, from tips to portal vein embolization, in certain patients, when you are planning for an extended hepatectomies or removal of large portion of the liver for tumors like that, then the residual, when there is residual liver volume is not enough for the existence of the life, we adapt this technique that now suppose you are going to resect the right lobe of the liver, we do the portal vein embolization, or we embolize the right portal vein. So that will redirect almost all the blood coming from the portal vein into the left side. So there is a there will subsequently there will be hypertrophy of the left lobe if you want to preserve the left lobe. So after 3 to 4 weeks, we do a volumetry and see the amount of enlargement. So once it is satisfactorily hypertrophied, then safely you can remove the pathological area. So these are the coils we use during portal vein embolization. You can see here coils has deployed into the right portal vein. So that is portal vein embolization. Then comes splenic artery embolization. So there are indications for splenic artery embolization. When you don't want to surgically remove the spleen, but there is hypersplenism, we can do splenic artery embolization. So same technique like in TACE, femoral approach, going into the aorta, find out the celiac axis. This time, catheter is negotiated into splenic artery, not the hepatic artery or the left gastric. So this is the dilated and tortuous splenic artery. I hope you can hear me.
Yes, Chinthaka, yes.
Yeah.
Okay, right. So, fine, I'm going to continue. So this is the dilated and tortuous splenic artery, and this is a hypertrophic spleen. These are the branches supplying the organs, and these are the coils used to embolize the artery. And the final angiogram shows a complete knockoff of the blood supply. So with that, vascular interventions, I will briefly discuss about some of the biliary interventions. They are commonly practiced in most of the hospitals, and sometimes they are really life-saving procedures, especially when the ERCP and endoscopy is failed. So this is one such example of a significantly dilated biliary system because of a distal CBD obstruction, and we can put external biliary drain, again puncture over a wire, the tract is dilated and a pigtail is inserted. So using that same technique, if we can negotiate the wire into the duodenum, through that we can put a metal stent or a plastic stent. For palliation, metal stents, and for temporary basis, plastic stents, like you do in ERCP. So antegrade biliary stents can be done. So the imaging modalities we use is both ultrasound and fluoroscopy. There are several treatment options for pain management. I'm going to highlight on one treatment, that is celiac ganglion neurolysis. So especially the patients with severe pain, for instance, in pancreatic CA and chronic pancreatitis. So if we can find out the celiac ganglions there besides the celiac axis, so what we adapt is we do mostly under CT guidance. Patient is again in the prone position, and we insert our needles from both sides towards the celiac axis. And then we usually use 100% alcohol mixed with a bit of iodinated contrast medium, like here. You can see the liquid material is nicely distributed around the aorta and close to the celiac axis. So that is called celiac axis neurolysis. I will discuss a few IR procedures we do for head and neck pathologies. This is one such example of a nasopharyngeal carcinoma. It's a devastating or it destroys many compartments of the neck when it comes to the latter stage. In this patient, there was erosion into the right common carotid artery. As you can see, there's spurting of blood, and it was a surgical emergency at that time on this patient. So this was on table urgent carotid stenting. There was a covered stent. There was covered stent was placed, and complete exclusion of the perforation was carried out, and the patient's life was saved in that occasion. And a standard practice is that my phone ringing or someone else's?
We can't hear Chinthaka.
Oh, okay. That's fine. Right. So glomus tumors, as you all know, they are highly vascular tumors in the head and neck region. So this is one such example of glomus jugulare tumor. If we can embolize pre-surgically, there will be a avascular field during the surgical removal. Usually, the pre-surgical embolization is carried out 2 to 3 days before. And this is the pre-embolization angiogram showing pathological blood supply. This area, this is the tumor blush. We call it tumor blush. And this is the completion angiogram following embolization. So subsequently, patient underwent safely for the surgical removal. Right. This is one example of juvenile angiofibroma. Adolescents sometimes presents with profuse nasal bleeding. When you image, you see these large, avidly enhanced tumors occupying the nasopharyngeal region. So the one treatment option, if you want to remove the tumor, it's going to be a blood loss. There will be a massive blood loss. And again, pre-surgical embolization will be done for these juvenile angiofibromas and other vascular tumors. So in this patient, the blood supply was arising from the internal maxillary artery. As you can see, this artery is hypertrophied. So the catheter is in the external carotid artery. You can see other meningeal and temporal arteries as well. But this internal maxillary artery is dilated. And this is the pathological blood supply, the tumor. And this is AP projection and this is lateral projection. And the final one is post-embolization angiogram. So patient underwent quite safely with relatively avascular blood field during surgery. In certain centers for retinoblastomas, selective cannulation of the ophthalmic artery and directly injecting cytotoxic or anti-cancer drugs can be carried out. So this is one such example of intraarterial chemotherapy for retinoblastomas. So the microcatheter is in the ophthalmic artery into the retinal region. And as you can see, the drugs is delivered into this pathological area. Then comes this acute cerebral strokes. I don't have to discuss about these aspects, co and all. And these things are done for large vessel occlusions, as you all know. And in this patient, the patient presented with sudden onset left-sided weakness, and there is dense MCA sign in this non-contrast CT brain axial image. And if you do MRI, you will see restricted diffusion in most of the areas. So if the criteria are fulfilled, patient can be taken into the cath lab, and mechanical thrombectomy can be attempted. So this animation video shows how it is done. So our guiding catheters will be placed in the common carotid artery and a microcatheter is advanced into this clot region. So in this illustration, there's a acute clot in the M1 segment of the MCA. Then through this microcatheter, so the microcatheter using a microwire, it negotiate through the soft clot distally, and through that retrieval stent is placed like this. So that's the stent. So it is deployed. It is deployed, and we keep for 4 to 5 minutes to incorporate the clot into the stent. Then this specialized guiding catheters we place in the proximal CCA. There's a balloon. Then the balloon is inflated like this. Then the forward flow is arrested. Then the entire thing, including the clot, is pulled out into the guiding catheter, and everything is taken off. So that is called mechanical thrombectomy. So these things are usually done in biplanar cath labs like this. Biplanar means we have two directional image acquisition. So one is towards the other one side, and the other one right angle to the next to the other one. So that is called biplane. Preferably biplane, but single plane is also good enough for these mechanical thrombectomies. And this is one good example of acute clot in the right MCA. As you can see here, there is paucity of blood supply in the right MCA territory. The normal ACAs and left MCA can be seen. When you do the angiogram, you see the abrupt cutoff at the M1 segment of the right MCA. And this is soon after the mechanical thrombectomy, revascularization of the MCA territory. Another example, this lateral projection shows complete knockoff or block of the MCA. And this is immediately after the mechanical thrombectomy, restoration of the blood supply in the blocked area. Another example, complete blocked at the M1 segment, and this is after revascularization. Right, a bit about coiling. When it comes to this berry aneurysms, if we can negotiate a small microcatheter like this into the aneurysm, we can safely advance and put number of coils like this. So that is called an endovascular coiling of berry aneurysms. So they are detachable coils we use like that. So this is one such example of 3D reconstruction demonstrating an aneurysm, ACOM aneurysm. So this is the aneurysm. You can see a narrow neck. So narrow neck aneurysms are suitable for endovascular coiling rather than wide neck aneurysms. So the same patient, angiogram shows this narrow neck aneurysm in the ACOM, and the coil is placed, and final angiogram shows exclusion of the aneurysm, preserving the rest of the normal cerebral blood circulation. Ranga, there's a background music going on. Is it disturbing to you? I can change the position if you want to.
No, that's fine.
No,
We don't need.
we can't hear anything though.
Oh, okay. Sorry. I'm outside, that's right. Okay.
You're enjoying music as well, Chinthaka. That's good.
Right. So in a patient, when we do a skull X-rays, these platinum-based coils can be seen like this, and those things will be there for the rest of the patient's life. So these things will create beam hardening artifacts when we do CTs. So we have to be a bit cautious about that. So these coils are usually MRI compatible, the newer coils. So that shouldn't be a problem, but it gives metal artifacts. So image distortion will be there in CTs, and beam artifact disturbances in CTs and MRI image. There will be image distortion. So similar endovascular techniques can apply to certain AVM, cerebral arteriovenous malformations, such as in this patient. So that's the large nidus, a compacted AVM, and this is the feeder. So these are the normal blood vessels, whereas this feeder is dilated, and there are large venous varix. So these are the venous varix. So these are the draining veins. So in these patients, no point of blocking the feeding vessel, but you should negotiate your catheters right into the nidus, right to the center of the nidus, and put liquid embolizing material. So this cast demonstrates that liquid material, it will be impacted or packed within the real nidus of the AVM. And this is the completion angiogram of that patient, nicely excluding the AVM with preservation of surrounding normal circulation. Like in coils, this is also gives they will be seen like this hard metal sort of things when we do X-rays in later life. Before I finish my presentation, I would like to touch upon this blood sampling, venous sampling for endocrine pathologies, such as adrenal vein sampling, then IPS test, that is inferior petrosal sinus sampling for occult microadenomas in the pituitary gland, then arterial stimulation venous sampling for occult insulinomas, and parathyroid venous sampling. This is one such example of arterial stimulation venous sampling. So two catheters are used. The sample collecting catheter is placed in the one of the hepatic veins, the second illustration, and the other catheter we place in several locations. So these patients present with, as you all know, hypoglycemic attacks. When you do ultrasound, CT, MRI, all will be negative, but the patient is symptomatic. Then the best gold standard technique is this arterial stimulation venous sampling. So in this patient, now in this venous sampling, we do, like I said, we inject calcium gluconate into superior SMA, then distal splenic, proximal splenic artery, proper hepatic artery, gastroduodenal artery, and common hepatic artery. So we catheterize each of these locations and inject calcium gluconate, and we take several samples from the venous side, from the catheter we place in the hepatic veins. So in this example, the test was positive for the distal splenic artery. So this was done in National Hospital a few years back. Then intraoperatively, we search the distal pancreas. We do intraoperative high-resolution ultrasound scan and found out this sub-centimeter tumor. So that was the insulinoma, and patient was improved subsequently. So that is called arterial stimulation venous sampling. Like I said, for occult microadenomas, hormone-secreting microadenomas, we can do inferior petrosal sinus sampling, like this. Then parathyroid venous sampling, another good study to carry out when you don't see the parathyroid adenoma. You do ultrasound, then 4D CT, MRI, but you can't see these tiny adenomas. Then because not only these adenomas are arising from the thyroid bed, but they can be in ectopic locations as well. So if you can see this diagram, we collect samples from 18 locations. I don't want to go into details, but from every angles. So that will give some idea about the location of this hormone-secreting tumor. So that is called parathyroid venous sampling. Similarly, adrenal venous sampling can be done before you operate incidentally detected adrenal tumor. If you want to resect, or when there is a hormonal imbalance, if you want to see whether this is active, so you do adrenal vein sampling. So left adrenal vein is draining into the left renal vein. It is rather easy to cannulate, but the right adrenal vein is directly draining into the IVC, so bit difficult to cannulate. So superselective cannulation should be done. Then samples are taken for analysis. So that is called adrenal venous sampling. So in summary, interventional radiology is an advanced medical specialty that utilizes imaging guidance to perform targeted, minimally invasive treatments. It plays a crucial role in modern healthcare by offering effective, low-risk alternatives to surgery, with quicker recovery time. So with that note, I would like to conclude my presentation. Thank you.
Thank you very much, Dr. Chinthaka, for this interesting lecture. Now I will post the link for the CPD certificate.
Sure.
You
Should
can
I
fill that
exit the-
form and the CPDs. Yes, please. Yes.
All right.
So, and you can fill this form and the CPD certificate will be directly forwarded to your email, and it will be open for 1 hour, and you can only send one response from a designated email. And
Can you post it?
you can
Can you share your post?
yeah, I have posted it in
No,
yeah. I have posted it in the chat box,
right,
sir.
okay, fine.
And you can similarly you can scan. Okay, what does happen? You can scan these barcode and fill the form as well. Can everyone see the barcode?
It's coming up. It's not yet, Ranga.
Is it?
Started screen sharing.
Can you see it now, sir?
We can't. Chinthaka, can you see? No. Ranga has started screen sharing.
We can go to the Google document.
Yeah,
Is that what you want?
so I have put
Yes.
the link in the chat. Yes.
Yes.
Ah,
You
yeah.
can go to the link.
And now we can see.
Okay. Okay. In the meantime, I'll go to the Q&A.
Yes, I was reading these
So
questions.
we have, yeah. Um,
If you are done with CPD thing, I can read out the questions and give some answers.
yeah. Yes, please.
Okay. Right. The first question is, when we ask for a therapeutic or diagnostic drainage of deep-seated abscesses, sometimes the answer is they are not approachable or the abscess size is too small. Is there a way of overcoming these limitations with advancing techs, or what is the size threshold for a diagnostic or therapeutic drainage of a deep-seated abscess? I'm particularly referring to the lung, liver, and spleen. The first thing is there is no size limit. The second thing is, if we can't see, we can't aspirate or put a pigtail. So For instance, if we are referring to the lungs, usually CT is needed unless the abscess or the collection is in the subpleural location. So when the collection is in the subpleural or within the pleura, only we can see ultrasonically. Then for the liver, almost all the time, we do our aspirations and drainages under ultrasound guidance. So it should be visible. If you need a diagnostic aspiration, even in a sub-centimeter collection, we can aspirate if you can see it clearly. So my first, the one answer for this, the long question is there is no size limit. Then spleen in selected case, yeah, sorry.
No, go ahead. Go ahead. Yeah.
Yes, spleen in
No,
selected.
go ahead. Yeah.
Yeah, sure. In selected patients, we do splenic abscess aspiration and we do biopsies for indeterminate lesions as well. So all in all, the image, the appropriate image modality should be there. Like we can't expect something to do with the deep-seated lung abscess when we don't have CT. So likewise, the location, the organ, and the imaging modalities, available imaging modalities are the key factors when deciding for these aspirations and drainages. Then I will move on to the second one. What are the limitations of coiling?
Yeah, I'll read it out. I'll read it out, Chinthaka.
Sure.
Yeah.
Yes.
What are the limitations of what are the limitations of coiling in belly aneurysms? Also, is coiling superior to aneurysm clipping?
Okay. So two factors. One is the location and one is the configuration of the aneurysm. Like I said in my presentation, when it comes to narrow neck aneurysms, they are in the coiling can be carried out. You can't do coiling for wide neck aneurysms because the coils will not retain within the sac. That will dislodge and migrate and cause infarctions. So then that is one limitation for coiling. Then there are certain other techniques like flow diverters, then balloon assisted coiling. So there are so many techniques, adapted techniques when the neck is not suitable. The other one is the location. For instance, the third most common location to get a berry aneurysm is M2 bifurcation, M1, M2. So bifurcation of the MCA. So they are towards the periphery. Then surgical clipping is much easier as compared to deep-seated PCOM aneurysms. So it's very difficult for us to say which one is superior because of these multiple factors. So the location for certain aneurysms, clipping is superior compared to aneurysms, vice versa.
Right. The third one is, when would you select microwave ablation over alcohol ablation for HCC?
Okay. Right. I didn't mention about this alcohol ablation, but alcohol ablation is another ablation technique. But having said that, alcohol is a liquid material. So we use absolute alcohol. We assume the liquid is 100% or at least 95% of pure alcohol. So it gives immediate dehydration of the cells. But being a liquid form, it won't distribute evenly without the tumor. So alcohol is less effective compared to microwave and radiofrequency ablative techniques. But I told that microwave and radiofrequency, they are powerful ablation techniques. So when the lesions are in difficult location, for instance, the lesion is abutting the gallbladder, or the lesion is right at the bifurcation of the portal vein, or if you think it is not suitable to do a microwave ablation for a tumor abutting the heart. So in these circumstances, if we can precisely place the tiny needle, we can attempt alcohol over microwave or other thermal ablation techniques. The other place where we use alcohol is when there is recurrence. Because one thing is cost effective. Alcohol is very less costly when compared to these other modalities. So for certain recurrences, we use alcohol ablations. But now in current practice, whenever possible, we try to manage the hepatoma with microwave and radio frequencies, most commonly microwave.
Okay. For mechanical thrombectomy, what is the time period from onset?
Yeah. For the anterior circulation, 4.5 hours, and if I'm not mistaken, I'm not sure about the very newest guidelines. And for the posterior locations, the basilar artery and the vertebral arteries, there is no time limit. Even after 24 hours also, if you think there is minimal risk of reperfusion injuries, you can attempt up to 24 hours for the posterior circulation.
After the ablation of a focal hematoma, how do you do the surveillance of the tumor? How often do you do the CT? What is the recurrence rate after the complete ablation of focal hematoma? And what are the treatment options if there's any recurrence of an ablated hepatoma?
Yeah, very comprehensive question and good one, because we did discuss during the presentation. So in most of the centers, and what we do is we do a follow-up CT or dynamic contrast MRI in 6 weeks. So that is our first surveillance cross-sectional imaging. So that will give the results, whether we have completely ablated or whether they are seen residual. At the same time, we assess the rest of the liver for any other remote occurrence, tumors. So the answer for the first surveillance, 6 weeks, CT or MRI. Then if it is complete, we do a 3 months cross-sectional imaging. And if that is also complete, we assume that a tumor has completely gone, and we have secured the patient. Then we can put the routine surveillance, that is ultrasound scan once in 6 months. Suppose patient have a baseline alpha fetoprotein level, then you do this AFP levels as well in follow-up settings. If there is any sharp rise in subsequent follow-up series, then we do close surveillance. That is one. And recurrent the outcome. In our local data analysis, out of I think 120 cases, 120 hepatomas, our complete ablation rate was 83%. So usually in anything above 80% is accepted. And so we expect at least 80% of the population we treat to get the complete results.
Okay, what is the place of interventional radiology to deliver certain drugs such as antibiotics or other directly inside the abscesses or tumors?
Now, if we can reach the location, we can, like we aspirate or like we put a pigtail, we can insert anything you want. I'm not really not sure about any specific indications for this thing, but certainly we can apply if there are recommendations. If you now, if you know, Ranga, if you have any guidelines for these things, then we can carry out, because we know the location and we can reach the location. Then certainly, if we can aspirate pus or fluid, the same technique we can apply and we can inject whatever you want. unless
What are the
unless it won't unless it won't contaminate the vascular supply and disseminate into the systemic circulation.
systemic circulation? Yeah. What are the indications for mechanical thrombectomy in stroke? I think we need.
I think we discussed about that.
Yeah, we have discussed.
Yes.
What is the usual life expectancy in a patient with liver carcinoma where radiotherapy failed to cure completely, and what are the remaining treatment options available?
So, like I said, untreated hepatomas usually 13 months for average person. Treated hepatomas, early detected, like in BCLC guidelines, we expect it to be more than 5 years survival. So, first, best 3 options are resection, transplant, and ablation. Then, for intermediate category patients and tumors, TACE, and some people, radioembolization. Then comes systemic therapy like sorafenib, and for the latter part, we don't do anything. That will be a conservative management, and those patients' life expectancy is little more than 3 months. So there is no survival benefit of offering the options we have discussed here.
Right. I think that's all for the questions. In the absence of any other questions, I would like to thank Dr. Chinthaka Appuhamy for this very interesting and comprehensive lecture. I'm sure our audience has benefited from this one immensely. And I thank him again because without any hesitation, he initially when we contacted him without any hesitation, he agreed to deliver this lecture, and I thank him again on behalf of the President and the Council of Sri Lanka College of Internal Medicine.
Thank you for the invitation.
Thank you very much. Thank you, and good night, you all. Thank you.
Thank you very
Thank
much.
you.
Chinthaka. Good night.
Thank you, sir.
Thank you.